All right, we can get started so we can stay on time. So first presentation is my worst TMVR complication by Dr. Estruas.
Hey everybody, my name is Carla Asturias. I'm a general cardiology fellow at OHSU, and it's a pleasure to be presenting to you our case, my worst TMVR complication, a case of valve in MAC complicated by late migration. I want to acknowledge my senior co-fellows and the structural team on this case. They were really kind mentoring me through that case, and I hope you enjoy it. We have no disclosures. And this case is about a 60-year-old male that presented with 6 months of worsening dyspnea. He had pretty extensive medical history, had severe MAC, had CAD, a prior PCI, had aortic stenosis with a bioprosthetic AVR, had also a pacemaker, paroxysmal AFib, hypertension, hyperlipidemia, diabetes, and chronic steroid use for polymyalgia rheumatica. His SDS score was 6.4%. And he was referred to our clinic because of these findings on transthoracic echo. Here you can see he had normal left ventricular function. The aortic bioprosthesis was with expected gradients, no significant regurgitation. But he had severe MAC with a peak and mean gradient of 19 and 9.1 millimeters of mercury. And with this, he underwent a transesophageal echo. Here, it re-demonstrated the severe MAC, and under anesthesia, the peak and mean gradient were 13.2 and 7.2 millimeters of mercury. Our mitral valve area planimetry was 1.38 centimeters square, and we also found mild to moderate mitral regurgitation. The patient underwent a CT that really showed that that MAC was circumferential with a CT MAC score of 9. The mitral annulus area was 830 and 880 millimeters squared on systole and diastole, respectively. The neo-LVOT predicted for a 29 millimeter sapien valve was 289 millimeters square. With these findings and with extensive multidisciplinary discussion, taking into account that it will be a reduced sternotomy, that the patient was on chronic steroids, that it was circumferential MAC, and most importantly, the patient's preference, it was decided to do a valve in MAC procedure with a 29 millimeter sapien valve. So we went transeptally, and here you can see the valve positioning. You can appreciate the MAC and how the valve, we thought it was in really good position. We inflated the balloon. We added 6 cc's to that inflation, and that was the end result that you can see on the right. Immediately after the index procedure, the transesophageal echo showed a pretty good result. The valve was well seated. There was no significant paravalvular or valvular regurgitation, and the transvalvular peak and mean gradients were 8 and 5. As predicted by the CT, there was no significant LVOT obstruction. And the patient went home within 2 days of the index procedure. However, approximately 4 months later, the patient represented to another hospital with hemolysis and a cardiogenic shock. And he was transferred to us for further management. Upon arrival to our facility, he underwent a TEE that showed that the prosthesis had migrated atrially. And here we can see severe mitral regurgitation with 2 main jets, 1 medial, 1 laterally, and also the peak and mean gradients were 13 and 7 millimeters of mercury. The CT that redemonstrates that the valve has migrated atrially, and we can see still that the MAC is there, and despite that circumferential MAC, the valve is more atrially. Again, after multidisciplinary discussion, it was decided that the patient would undergo a TMVR with valve in valve, and this is what we did here. Here we were a little bit nervous at the beginning of the procedure. You can appreciate the MAC around the index valve, and you can see on the inferior aspect of this how the valve is truly like just hanging there, like the last rod of the valve, really. So we were really careful positioning the valve. We were able to cross it without any issues. We performed a really slow inflation of that second valve. We were really happy with the end result. We inflated the balloon with extra 7 cc's. This was the end result. Here you can see the two valves. They're on top of each other, and we can see the transesophageal echo at the end of the procedure. Really trace paravalvular leak, no significant regurgitation, and the gradients were, again, 8 and 3. This is a transthoracic echo performed 4 months after the second procedure. The valve was well seated. There was no significant paravalvular leak or valvular regurgitation. There was acceleration of flow in the LVOT, but no significant gradient. And just as learning points for this case, sapien valve in MAC is feasible in certain anatomies. Lane migration could happen, especially in the atrial direction. Both PVL closure and redo TMVR are viable options for these cases. And we cannot emphasize enough how careful procedural planning and proper valve sizing are essential for these patients.
So one question I have for you is the leak was skirt leak, is that correct?
What was that, sorry?
The paravalvular leak that it was thought was skirt leak because of migration, so the PVL closure was not an option. You had to redo, is that correct?
Yeah, we thought that the area of the leak was too big for that. Also, we didn't accommodate other forms of closure, like a specific plug or a specific device. So we thought that this would be the best option for the patient.
Any questions, guys? Well, this is your case. Any?
I will definitely not vote on this case, and because of conflict. But I will also definitely wish that it was not my case. This is a tough lesson for all of us as we deal with MAC. It is not an easy disease, and I think this case demonstrated that even sometimes you get good acute results, patients need to be followed because the amount of pressure that push those valves atrially is not insignificant. We typically like to flare the valves on the ventricular side so they cannot move atrially. In this case, we ran out of volume to put in those valves, so we could not flare it. And the second valve was deployed, a little off axis on the first valve, so so it gets stable in place.
Great, thank you, Dr. Sears.
Thank you.
So the next case we have is challenging TAVR access in patient with severe PAD by Dr. Randhawa.
All right. Hi, everyone. Thank you, CBI, the organizers, for having us here. And I want to thank my mentor for the case, Dr. Zulkarnain, that we did the case with. Let's see if this goes forward. I don't have any disclosures. So the case appears to be pretty straightforward. It's an 88-year-old guy, comes to an outside hospital in the Periphery in Arkansas with new-onset hypoxic respiratory failure. He has bilateral chest infiltrates. So he's diagnosed with pneumonia. On second day of hospitalization, his BNP comes back over 25,000, high sensitivity troponins 1,500. He has new-onset heart failure. An echo over there shows an EF of 25%, a gradient of 41, and severe AS. And he's transferred to us for an urgent aortic valve replacement. This is his EKG on admission to our facility. It just shows LVH, Cornell product or Cornell criteria. Nothing else that's significant, a prolonged QDC. So day one of hospitalization, we think this is an 88-year-old with no other history. The plot kind of thickens. On the health record, there's a small tab that says outside information available. And we start looking at this. He has records from Louisiana. So 12 years ago, supposedly, he had an office visit with a cardiologist. No known reason why. But he had a transthoracic echo with EF that was normal and moderate aortic stenosis with a valve area of 1.12. He subsequently had a cath at that time because the idea was that he would need an aortic valve replacement at some point in time. And over there, he had the report said he had a RC occlusion, circ occlusion, 70% LAD disease, left to right collaterals, and he was essentially surviving off of the LAD. And he also had PAD with left SFA occlusion, but the patient was asymptomatic, so he denied any interventions. Then 10 years back, prior to admission, he had AAA that had ruptured. Not ruptured, but had a leak. So he had an EVAR for that. 8 years prior to admission, he had moderate AS again, stable EF, valve area was stable. And then 7 years before the current admission, he had a type 3 endo leak. His aneurysm went from 4.6 by 4.4 to 5.9 centimeters. So apparently, there was an attempt to snare off the previous EVAR. The report says the snare broke, and the snare could not be retrieved. So an endologic stent was implanted within the EVAR graft, and the patient was sent home. So now he comes to us, and we are saying, OK, what can we do with this guy? And just for everyone's purpose, I'm sure everyone who does peripheral is well versed with this. But an endologic graft has two parts, the body and the kind of the limbs you see on the end. They go in three separate, they're all diploid, kind of apart from each other. This is not a graft that goes up as one single graft. So what we do have for him on this hospitalization, we repeat an echo. His EF is 25%. Vmax is 4.2. Peak gradient, mean gradient is 40. His DI is 0.19. AVA is 0.8. So luckily, his RV function is normal. PS systolic pressure, RV systolic pressure is 35. So not terrible. We do a cath, and essentially what we see as a prox RCA CTO, he has epicardial right-to-right collaterals. His LAD he has a mid-LAD lesion. It's actually not a circ CTO. He had really more of a OM2 that was CTO, but he was having decent collaterals from left to left and left to right. And just take a look at the CT, because I want to see how many people can track a lumen and see which lumen would they go for. So you start seeing 2 lumens there. Now you start seeing 3 grafts in there. And we're trying to figure out what is exactly the most recent EVAR graft. And what do we go for? What do we shoot for? If we have to dilate something, what do we do for this guy? So just to show you the same image backwards, now you're going from low down, back up. Try tracking the iliacs and see what lumen would you try to shoot for. So up until there, everything looks OK, and then everything gets super narrow, and you see 3 lumens kind of coming together right next to each other. So our CTA, it basically showed a perimeter of 86. Area was 563. The coronary heights were OK. Right subclavian diameter was 8.8, because we were expecting that we may need to go alternate axis. Left was 6.8. Bilateral carotids had about 60-70% stenosis, so transcarotid wasn't an option. So the challenge for us was his operative mortality is 5.64%. Morbidity mortality is 18.2%. No surgeon's going to touch him. The question was, what do we take as axis for him? Do we, if we're going transfemoral, do we go through the graft? The lumen is compromised, the snare is broken. Where are we going to exactly end up with this? Transcarotid, because of the carotid artery disease, was not really a great option. Not that it's not an option at all, but not the best option. Transcaval wasn't an option because he has 2, at least EVARs that we know of that are sitting in there. Subclavian would mean a cut down is required, and the last option was transapical. So we had a multidisciplinary meeting with our surgeon, with the vascular surgery, and we decided to proceed with transfemoral TAVR. We had vascular surgery on standby. We had a 30 balloon in the room available in case anything went wrong in the aorta so that we could go up and inflate the balloon. The valve that he was sized to was a 34 Medtronic, and he was a candidate for a backup salvage AVR. So this is the first shot that we look at. Not great flows in the legs. We got bilateral access. Our primary access for delivering the valve sheath was right. TVP was going up via the left. We actually ended up going pretty smoothly with a true balloon, a 23 true balloon, to do a balloon valvuloplasty because it was a very heavily calcified annulus, and it was a 34 valve. So we went up. We did OK. We come back down with the true balloon, and now we try to go ahead with the valve delivery sheath. And it gets stuck. And it's getting stuck right over here, kind of where the red arrow is. And it wouldn't go beyond this point. This is kind of where the snare was broken. So we talk to our vascular team, we take a look at all of the images, and we find that the right iliac limb of the graft is not in continuity with the main body of the rest of the EVAR graft. And the wire was essentially tracking under one of the stent struts. What we did was we took inspiration from how you come across radial loops. We did balloon-assisted tracking. We used a glide wire, an angle glide catheter, and balloon-assisted tracking to kind of avoid going under the stent struts. We were able to eventually get through into the true lumen of the EVAR. We did a peripheral angioplasty first with a 7/40 and then a 10/40 ultraverse balloon. And then once we did the peripheral angioplasty, we went up with the valve delivery system. The valve was deployed. Didn't have any issues with the valve deployment. And the angiogram on the right side is after we had closed the access on the right side with MANTA. So didn't have any issues. Just the key learning things, I think, for this case is alternate access is not always necessary. Transfemoral TAVI can be a safe option as long as you include all of your options and you include all the team players, not just a cardiac surgeon, but also a vascular surgery team. Valvuloplasty balloon may go through the stent struts, giving you a false sense of security that you are in the true lumen while you may actually be tracking under the struts. And then balloon valvuloplasty is sometimes needed. I know there's results of the direct TAVI trial where it shows that you don't necessarily have to predilate calcified annulus. But then also in the same trial, there's reports about that you have to carefully consider the patient. So in a heavily calcified annulus and a self-expanding valve, it's not unreasonable to do a balloon valvuloplasty before. Thank you.
So 2 questions. One is, what sheath was the size of that got stuck in the endograft? Was it a 16 or 18?
It was an 18 sheath.
And when you took a BAV balloon, what sheath was that, through 8 French?
That was through a 10 French sheath.
Because we had a similar case. We did actually EVAR TAVR together, and there was a metal-to-metal lock that's not easy to get through sometimes.
Yeah.
So fantastic job.
Thank you.
Yeah, Sandeep, this is a great case, and I think you demonstrated 2 important things. Is one, the importance of multidisciplinary team and the discussion with vascular surgery about the best approach. And the second thing is the importance for CT for planning. I saw that you went through it even in the presentation twice. That tells you how important it is to look at the CT. The other thing is the question for you is, what was your plan if you were not able to get the equipment through?
So 2 things that we thought of. We thought that we could potentially try the other side in terms of transfemoral, because it was really confusing when you look at the anatomy of which limb of the EVAR graft is in continuity, which is not, and how are they playing into each other. The alternate option for us would have been a right subclavian cut down, left subclavian cut down, I apologize, because that was the bigger of the lumens. But again, subclavian cut downs, slightly higher risk as compared to transfemoral TAVIs. We wanted to avoid alternate access if we could.
That's wonderful.
Thank you.
So your next case, ascending aortic dissection after TAVR with Dr. Adamic.
Thanks, everybody, for being here. My name's Kylie Adamack. I'm one of the interventional fellows at Vanderbilt University. Really excited to present this case, and I'm figuring out I don't know how to advance my slides. One second. Green button, all right. Really excited to present this case from last spring at Vanderbilt. Huge thanks up front to Drs. Kashish Goyal, Dr. Andrew Clucky, as well as Dr. Chetan Pashrija for help with this. I have no disclosures, and we're just going to kick it off with the case. So this was a 65-year-old gentleman who came in kind of with your standard aortic stenosis symptoms. He was having NYHA3 class symptoms for about a year. Fortunately, had not had any syncope or heart failure admissions, but had quite a few cardiac comorbidities. So as you guys can see, moderate TR. He had AFib, hypertension, hyperlipidemia, HFpEF, which ultimately gave him an STS risk score of 4.53. So he sort of underwent a heart team approach as to how we would fix his severe aortic stenosis. There was a little bit higher concern given his BMI of 44, and the patient actually strongly preferred TAVR. And so after some shared decision-making, the decision was made to move forward with a TAVR approach. The procedural strategy was decided on to be a 26 millimeter Sapien Ultra via transfemoral approach with max sedation. And just to give you guys some quick visuals of what his aortic stenosis looked like, fortunately preserved EF for this gentleman, Vmax 4.47, and his mean gradient was 48 millimeters of mercury, which gave him an aortic valve area of 0.7 centimeters. And as y'all can see, in AFib during his echo. And here we can see a little bit of that calcium along his aorta. Sorry, can I go backwards? Oh, all right. So during his valve deployment, upon initiation of rapid pacing, you can see his valve actually slipped into the LV sort of incidentally. So rapid pacing was stopped and the valve was actually pulled back. And what I want people to take a little bit of note of is where the delivery system is sitting right now, because that's going to lend some context later to our complication. So the delivery system was pulled back and repositioned, and the valve was successfully deployed. Following valve deployment, there was a little bit of concern for paravalvular leak, and so a post-deployment angiogram was done. With that, you guys can actually see a little bit of a radiolucent line here that was concerning for dissection. So we actually asked for some help from our anesthesia folks to get an intraprocedural TEE done. Despite them successfully doing that, we weren't able to get great visualization of it or really characterize what the dissection looked like, how extensive it was, et cetera. And so the decision was actually made, because he was hemodynamically stable, to pursue a CT. And you can see here that dissection plane, which starts about 20 millimeters above his sinotubular junction. And we'll get into a little bit more of the anatomy in a second, but this was just a visual I wanted to show folks. So ultimately, after reviewing the CT, a lot of questions came into discussion, particularly with our CT surgeons who were helping out with the case at the time. And one of the things that came up was the possibility of a TEVAR for this gentleman. The outer curve length of the aorta from the sinotubular junction to the brachiocephalic trunk was only 10 centimeters. The maximum aortic diameter was 33, and the entry tear, as I showed, was about 20 millimeters above the sinotubular junction. So they actually thought this was going to be a perfect candidate for doing a TEVAR. So ultimately, in keeping with the patient's initial preference to avoid any sort of open surgery, the decision was made to proceed with TEVAR with a 34 by 100 millimeter Gore conformable tag stent graft. This was deployed just above the coronary origins and just below the brachiocephalic origin approximately. And then a repeat CTA was done after this, which I'll show you guys in a second, with complete occlusion of the dissection, as well as good perfusion of the innominate and coronary arteries. And this, really proud of these images. This is from Dr. Bruno Lima in our imaging department, who was able to actually create a reconstruction. I have post-TEVAR there. This is actually pre and post. So you guys can actually see the dissection plane and sort of where it sits, as well as where the TAVR is, or TAVR and TEVAR sit as well, completely occluding that dissection, as well as with good perfusion of those arteries. So my learning points for this, type A aortic dissection is rare, but potentially a catastrophic complication of TAVR. Fortunately, if limited to the ascending aorta in between that sinotubular junction and the brachiocephalic trunk, TEVAR appears to be a feasible option for open repair. I'll open it up for questions.
Dr. Adamek, I know your slide skipped. Could you tell us the pre-op CT, pre-TAVR CT, what you saw on that?
Sure. Can I go back? I can't go back to it, can I? So on the preoperative, I'm unclear exactly what so I know he had no evidence of PAD, so I knew the access site was felt to be appropriate for a transfemoral approach. And then as far as the anatomy goes for the TAVR valve, I'm drawing a blank on what his actual dimensions were, but ultimately felt to be appropriate for the 26 millimeter Sapien.
And this was not bicuspid, just to clarify, or aorta was normal?
Correct, yeah. Actually, despite his age, there was actually a lot of question as to whether or not he was bicuspid. As you guys probably saw with his echo, not great views. And that he'd actually had a couple echoes before that, and despite that, we weren't able to visualize the valve super well. Similar on CT, there was maybe a question of right-left diffusion, but it wasn't a clear bicuspid valve. Great question.
Well, this was a fantastic case, and I'm happy that Consta is here. But I have a comment. I don't know. I saw Kashish, a second ago. Yeah, I mean, Kashish, we just like me. We present the success next door, and we let the fellow present our complications. So I think the big question that we have is, how those dissections happen. And is it a bicuspid valve to start with, and this is why the aorta was fragile, and is it as we're coming around the arch that this happened? Mm-hmm. And I'm curious because you go home after a complication like this and you keep thinking about mm-hmm. it. The way that you handle it was beautiful. And but can you walk us through the management of the blood pressure, the management of the patients, even like the details about how you go from the table to the CAT scan back to the table?
Yeah.
I mean, the logistics of that are also not easy. And
yeah.
Can you walk us through how you managed it?
Yeah, I think that's an exceptional question. And I think going back first to your initial point about how the dissection happened and commenting a little bit on whether or not this was a bicuspid valve, because an iatrogenic dissection is very different than one that occurs in somebody who may have a bicuspid valve or may have a connective tissue disease. In one, or in the latter, I should say, the substrate, there's something innately wrong with the tissue of the aorta versus an iatrogenic one. It's something that we did. And so one may portend a worse prognosis down the road. We know that a dissection that happens sort of de novo in somebody with, again, a connective tissue disease or something innately wrong is not going to fix itself. And so for us, I think one of the big questions when this happened was that based on the location of it, was this something we caused with the pusher, with the delivery system, and how it was sitting against that outer aortic curve? And if so, is it something that we could have left alone? The dissection plane was retrograde from the blood flow from the aorta. And so those things sort of gave us a little bit of pause initially. And I think it wasn't until we got those anatomic considerations that just kind of were perfect for this guy to undergo TVAR that we really considered fixing. Because I think leaving it actually could have been a plausible course.
Thank you, Dr. Almek.
Thanks.
All right. Our next speaker. Yeah. Our next speaker is Florimon Jose Garcia, Joseph Garcia. He's going to talk about entrapped underdeployed position left main coronary artery stent in a patient undergoing transcatheter aortic valve implantation. The case report.
Hi, so good afternoon, everyone. I'm Dr. Florimon Joseph Garcia, and I am from the Philippines, the medical city, and I am here to present the case of our TAVI team composed of Dr. Prado, Dr. Marañon, our cath lab head, Dr. Sabas, and our training officer, Dr. Fortuno. I am currently an interventional cardio clinical research fellow there. So for my case today, we have entrapped, undeployed, prepositioned left main coronary artery stent in a patient undergoing transcatheter aortic valve implantation. So for my disclosures, I have none. So for our patient, she is a 91-year-old Filipino female who came in with the chief complaint of chest pain. For the present history of the illness, the patient was having chest pain for about 2 months. The initial cardiologist that checked the patient managed her medically and gave her meds for the chest pain, heart failure, and treated her as chronic coronary syndrome. And then 1 month prior to admission, the patient was advised to have a coronary angiogram, and 2D echo was done at that time prior. So it showed severe aortic stenosis. However, the LV function at that time was normal. Then coronary angiogram was done, and it showed an 80% proximal and mid-LAD stenosis, and the patient underwent PCI of the LAD at this time, with the plan for TAVI. So assessment at this time was valvular heart disease, severe calcific aortic stenosis, chronic coronary syndrome, one vessel coronary artery disease, status post PCI of the LAD, and sinus rhythm, functional class 2. So here's the transthoracic echocardiogram of our patient showing the severe aortic stenosis with an aortic valve area of 0.77 with a mean gradient of 41 and a peak velocity of 4.15, showing also concentric LVH with normal wall motion contractility and normal ejection fraction. So this was the final conclusion of the 2D echo of the patient. The other valves were unremarkable. So for the pre-procedural CTA of the patient, it showed LCA ostium height of 10.5 millimeters with an estimated left leaflet measuring 12 millimeters. So the other values were within range. So the concern for this patient was with the ostia height of 10.5 for the left. So when we were doing the planning for this patient, for the TAVI, we were thinking that would this close the left coronary artery? So with that, initial hemodynamics showed a peak-to-peak gradient of 54, so it was supported of severe aortic stenosis. So using an EnveoPro delivery system, we then deployed a 26 millimeter Evolute Pro valve across the aortic annulus at 2 to 3 millimeters depth below the annular plane. And TEE post-TAVI showed negligible transvalvular gradient. So at this time, we were thinking we're almost done. We're having a successful procedure. But then the problem comes. So for the clinical challenge, aortography showed no aortic rupture, dissection, and regurgitation, still with continued patency of our coronary arteries. However, on attempt to withdraw the prepositioned left main stent, the catheter was entrapped between the calcium in the sinotubular junction and the valve frame. So this resulted in failure to remove the stent with partial stripping of the mounted stent from the delivery balloon. So what was the resolution of the team at this time? So we were thinking of multiple ways to tackle this case. So number one was just to try and remove the balloon and then put another system there and try to crush the stent that was left behind there. Another was to deploy the stent, and the part that was not inflated, the stent that was not deployed, we would just crush it or fix it with another system through the valve stent struts. So the ending was the stent was deployed at the left main artery in a chimney fashion in the aorta. However, when we tried multiple techniques to access the left coronary system again, we were able to wire the LCX and LAD. However, when we were putting down the balloons, it wasn't going down anymore. So as you can see in the video on your left, you can see the distal stent struts that were stripped of the balloon, pre-deployment of the stent, and afterwards you could see that there is an expanded proximal to mid-stent strut, and there was an unexpanded distal stent strut. So at this time, we tried to reaccess it with another guide, and then we rewired both the LCX and the LAD. So we were successful in that technique. However, we tried multiple techniques to bring down our balloons to further fix the unexpanded stent so we could crush the part that was not deployed. So we tried everything. We tried guide liners. We tried different guide catheters. However, we were unsuccessful. And it was already taking us about 2.5 hours just to access this. So this was the time when we were humbled and we just decided that the patient had a TIMI-3 flow. Vital signs were stable, and probably it was time to stop and check out on another date or another time if the patient would improve or not. So luckily, the patient improved after 3 months follow-up, 6 months follow-up, and already a year of follow-up, and the patient is doing okay. So for our key learning points for the operator and the team, so transcatheter aortic valve implantation can be a safe intervention in patients with high risk of aortic valve surgery. Coronary artery obstruction is a very devastating complication in TAVI and should always be considered despite its rarity. And bailout strategies should always be in place prior to doing the procedure by planning well and properly knowing the character of the equipment used in the procedure. So with that, thank you very much. Maraming salamat at mabuhay po.
So Dr. Garcia, thank you. That was excellent.
Thank you, sir.
The question I have is why you thought that you need to protect left coronary? The sinuses were 27-ish, if
Yeah.
I remember, and coronary head was okay. And
Yeah, the coronary height was at 10.5. However, it's not usually measured, but they measured the left leaflet, and it was about 12.5. So they decided, my consultant decided to protect the left main at this time, not knowing that this would happen.
And after you deployed the proximal part of the stent, the wire came out or it was pulled out intentionally?
Actually, it came out when we pulled it after.
Oh,
It
thank you.
was actually intentional.
That's a great case, and thank you for sharing it with us, and thank you for
Thank you,
bringing it. My question is, walk me a little bit through the procedure. So you guys deployed the TAVR valve.
So we
and then
deployed
you
the yeah.
You pulled the guide back, and then you pulled the stent, or your guide got pushed back after the valve was deployed. So
When the valve was deployed, I think the guide was pulled back a little bit, but it had the right angle. So if you try to pull the stent outside, it would bump into the right angle because it was stuck in between the valve and the calcium. So it's either we were thinking we pull the whole system as one, or try to fix it first. We have another guide, try to crush it with another stent, or we could just deploy it, then fix it after. So at that time, tensions were high, so the plan was just to deploy it and access again.
I know teams in the past have chatted about a lot of times just leaving a guide extension and just pulling back their guide to avoid that like sinuses being like really sequestrated from your guide and making it easier afterwards because your guide extension will sit deep in the left main and then you can easily get it
That
out.
could have prevented it if we had a guide.
What's your
extension.
strategy for antiplatelet after?
Actually, that was the thing.
Because you have a pretty underexpanded stent.
Yeah. So we were thinking, should we do dual antiplatelet only or triple therapy? So at that time, the attending physician started the patient on triple therapy. Though the patient was 91 years old, we just monitored her regularly. At 3 months' time, she was able to tolerate it. Then after the 3 months, they shifted to single antiplatelet and anticoagulant. So the patient reached 1 year without any bleeding complications at this time.
Thank you. Any questions from the audience? Thank you, Dr. Garcia.
Thank you, sir.
So next we have shockwave-assisted lampoon by Dr. Ourn.
All right, hi everyone. I'm Charlene Rom, here to present lampoon-assisted lampoon, shockwave-assisted lampoon. So we've got a 60-year-old woman who presented with progressive dyspnea. She does have a past medical history of rheumatic heart disease, which brought her a 27-millimeter complete semi-rigid ring implanted in 2006. So we had a diagnostic echo done, which does confirm she's got a severe stenosis of her mitral valve with a diastolic mean gradient of 11 millimeters of mercury. After a multidisciplinary discussion, team discussion, we decided to proceed with a transcatheter mitral valve intervention. So we obtained pre-procedural planning CT. And here on our CT, we see that the simulated neo-LVOT area post transcatheter mitral valve replacement with a 26 millimeter valve would only come out to be about 139 millimeters squared. So this puts her at a high risk of having LVOT obstruction post TMVR, since we have a neo-LVOT area less than 200. So then we decided that lampoon would be a good strategy to help minimize that risk of LVOT obstruction. So here in our lampoon simulation, then the skirt neo-LVOT area was adequate and acceptable at 363 millimeters squared. So given that, we decided that it was appropriate to proceed to the cath lab. So we brought her in. The clinical challenge then here is we are performing lampoon on a highly calcified and a restricted anterior leaflet. So how do we do that? So here again, let me see. There on the anterior leaflet, you see it's thickened, it's calcified, also confirmed on CT here. You see that anterior leaflet has a big chunk of calcium right at that A2 portion, which is where we would be lacerating. So how did we achieve this? We decided that we might need to modify this calcium. So here we are with the procedure. We perform transseptal puncture per the usual approach. We go in antegrade, and we've got our 2 guides across that. We performed we placed an Estado wire, snared the Estado wire into the JR4 with an end snare, and over that wire we placed a balloon at the base of the mitral leaflet there with a 30 millimeter NC balloon. We treated that area just so we can open that area up so we can fit our equipment, fit our guide. And then because of how highly calcified this leaflet was, and we anticipated difficulty in lacerating this anterior leaflet, so we opted to use a shockwave balloon, a 4.0 coronary shockwave balloon. We delivered 30 pulses right there at the base, and then proceeded to attempt a base-to-tip laceration. That was our initial attempt. So here, as you can see, where we apply electrocautery to our Estado wire, we attempt to do a base-to-tip laceration, but then on TEE imaging, we saw that it was an inadequate laceration. We attempted almost an hour, about 45 minutes of this. The problem was the catheter kept slipping medially, kept slipping toward the side of the aorta, and despite multiple attempts, it was not successful. So then that's when we switched gears and attempted a tip-to-base laceration. All right, so then with a tip-to-base approach, here we did obtain left femoral artery access and created a veno-arterial rail, again with an Estado wire. So here we see in the ascending aorta, we've got our JR4 guide, and then we extruded the Estado wire, veno-arterial rail, and then with that, we performed a tip-to-base lampoon, applied electrocautery, and you'll see here, that was a successful approach to lacerating this anterior leaflet. And we did confirm on intraprocedural TEE that on color imaging, that was sufficient. So that's why we then proceeded to implant our valve, which was successful with a 26 millimeter Sapien 3 Ultra valve. We did not have any PVL, no regurgitation post-implant. Unfortunately, post-lampoon, we had an LVOT obstruction, measured mean gradient of 24 millimeters of mercury, unfortunately. So to back up, she did have some basal septal hypertrophy, and this was a thought how to minimize our LVOT obstruction risk. We proceeded with a lampoon. However, we decided that another approach would be to proceed with alcohol septal ablation because on pre-procedural cath images, she did have a viable anatomy for this, the first septal perforator, so we did bring her back the next day, performed alcohol septal ablation. As you see, that reduced the LVOT mean gradient to 7. All right, so some learning points here we've got. So in summary, it was a challenging TMVR, challenging lampoon of a highly calcified and retracted anterior mitral leaflet. We suggest calcium modification techniques with a shockwave balloon, which can help fracture calcium on the mitral leaflets. We performed a tip-to-base lampoon, which is ultimately what helped us lacerate this anterior leaflet. And keep in mind, this was a safe and feasible approach, especially in patients who have a pre-existing bioprosthetic mitral valve or have a bioprosthetic complete ring, because it does provide a backstop, essentially, to prevent extension of your laceration to the aortic valve or to atrial structures. And then lastly, you might have to consider a combination of procedures to minimize or to prevent LVOT obstruction. So, for example, in our patient, we combined a lampoon and an alcohol septal ablation technique to achieve the results that we did. All right, and thank you very much.
That's fantastic case. Thank you for presenting. Few questions. One is, this patient's still 60-year-old.
Yes.
Why he was not a redo candidate?
So she had multiple comorbidities, and after our multidisciplinary multidisciplinary team discussion, she was considered high risk for surgery. I think her risk actually calculated to be about 10 or 11% risk just because of her comorbidities. And then also discussions with her, she preferred if we could come up with a strategy to do it transcatheter based. So that was how we discussed it.
And we never done in our center shockwave lampoon. So educate us, which patients does it work and when do you consider it?
Yeah, sure. So with her, lampoon, has been described. It's been done. That's not a secret. What is unique is we thought of coronary techniques to break down calcium, and with her problem was that highly calcified anterior leaflet right at the spot where we need to lacerate A2. So we decided that since shockwave has done wonders for us in the coronary to break down calcium, we figured it'd be a reasonable method to try. There's actually been a small case series that was recently published, actually it's actually a year ago now. Small case series, there were 3 patients who underwent actually balloon-assisted laceration, balloon-assisted lampoon, and then 2 of those cases, they used a shockwave device as well. So it has previously been described, and we thought it would be a helpful procedure. Unfortunately, it didn't help us with a base-to-tip technique, but it did, I think, ultimately help in reducing the amount of calcium so that we could perform a tip-to-base lampoon.
So what's your algorithm when you have this kind of patient? If you see a calcified leaflet, you automatically go to shockwave, or walk us through?
Yeah. Well, this is our first time doing this. So I think what we did was we wanted to do a transcatheter mitral valve replacement. We saw that there is calcium. I think if there's a highly calcified leaflet, it is reasonable to perform these adjunctive procedures. So I think that's where the decision tree is. Are we looking at calcium or no calcium? If there's no calcium, then I think we can proceed with our traditional laceration. If there is calcium, that's when you need to consider these adjunctive measures such as shockwave. So I think that's where the decision lies, the presence of calcium.
And I know you worked at Dr. Gold's lab. He didn't do Batman?
No, we have not.
Beautiful case and well done. I think my one question would be, why did you pick a 4.0 balloon? Like, how do you pick up the size, I guess, of the balloon? Do you feel that like 4.0 will give you a better contact? Because for your shockwave to work, you have to be touching the calcium. So
well, so we initially had gone up with a 3.0 NC, so then that's already dilated open, so we wanted as much contact as possible. And that was actually the largest balloon that we had available, shockwave-wise. So then we ended up going up to coronary-wise a 4.0 coronary balloon. We definitely did not want anything smaller than the 3.0 NC that we used.
My second question is, do you see on TE after your shockwave, do you see any difference in like calcium distribution or like how the leaflet was behaving? It's been a little debated of whether truly like the shockwave helps in that type of calcium or not. And it actually, I really hope it helps because it's going to open up a lot of new.
It would open up a lot of doors, yeah.
So I'm curious to see if we're like, because I'm sure you were doing TE at that time, if you actually see like more mobility of that section of like, or more kind of like fracturing in that calcium that would actually allow you to be more comfortable that now your stado will cross it.
Yeah, that would be reassuring if there's a way to confirm on TE. So we did have TE imaging throughout the entire procedure. Essentially what the biggest thing that we looked at really was the color flow imaging, if we had even greater color flow to determine whether we had an adequate laceration, which we did not initially. So I think maybe assessing the amount of color Doppler, amount of flow through that area, if it's increased or about the same, is reasonable.
Great. I think there was a question.
Yes.
How do you know that your tropical emitters are not continuous? So you might be caught at the level of the leaflet in between the emitters, and you might have no tropical effect. So that's the challenge which I find in reducing or fracturing the calcium in the tropical, because if you are in between the emitters, it's not going to do anything, it's just to do effect. That's number one comment. Number two, I think I'm sure Prakash is with you
Yeah.
I think the second thing, your point is right. She was a case for tip to base. It's just that you were not very happy with the base to tip, so we said, okay, let's elasticate more. And then the second point was, we didn't do the septal ablation right away, but she actually was hemolyzing next day, which was very interesting. There was no PVL, but there was LVOD obstruction and hemolyzing. So that's why we had to bring her back next day. And actually she left, and then she's doing fine. So, your point is good, not to do it in the same, but the reason we're doing it was actually more for hemolysis.
So you bring up a good point. That is a major implication because we had one case as well, especially if you're along and the leaflet with the middle mitral valve. It may cause SAM in the LVOD, which may hemolyze. And we have had to actually put another valve in that situation as well. So yes, I think that is the most urgent indication to do septal ablation. Would you do Batman right now?
So again, we've discussed a lot Batman during this
Yeah,
conference.
we did.
We have to do one now. But again, the issue with Batman came up again is if you have a very
Calcium.
leaflet, are you going to just lacerate the valve and pistonate it, and
Yeah.
will it cause injury to the aorta myocardium? So I think in this case, I probably still would not do Batman. For Batman, I would like a mobile, nice leaflet to just get it out.
All right, thank you, everybody. We'll move on in the interest
Actually,
of time.
real quick, before we move on, if I could ask if Dr. Wali Omar or Dr. Rahul Swani are in the room to come back to the AV desk, please.
Perfect. So next speaker is going to be Mohammed Zagoussi. He's going to be presenting on novel use of the ulnar retrieval system for ruptured balloon tube.
All right, thank you for having me today. My name is Mohammed Zagoussi. I'm a second-year fellow out of UHC Nashville, Ascension St. Thomas Heart Hospital. Today I'm going to be presenting a novel use of the ulnar retrieval system for a ruptured balloon tip. So I have no disclosure. Before I start my presentation, I would like to acknowledge my attending who helped me prepare this case, Andre Morse and Sassan Raisi and Vili Rodriguez. So my case is a 67-year-old man who presented with increased dyspnea of exertion and lower extremity swelling. His background, he had a bioprosthetic mitral valve replacement in 2004. He has 6 sinus syndrome. He has AFib, and he has chronic HFrEF with EF of 20%, and he has BIV ICD that was placed in June of 21. So in the spring of 2023, he was admitted to an outside hospital and was diagnosed with Streptococcus bacteremia, and he received 4 weeks of IV antibiotic therapy as an outpatient. He initially felt better, but he returned to the clinic for follow-up in the EP clinic, and he was found to have worsening heart failure symptom and a new murmur on exam. And this is his TE. You could see that he has a severe MR, and what it appears to be possible vegetation on the leaflet. So the clinical challenge with this case, so the patient had severe MR. He had vegetation that measured about 1.6 to 0.7 centimeter. He's a Jehovah's Witness, so he is not amenable to receive blood products. His hemoglobin baseline is 10.4. He's also a thrombocytopenic, and his platelet count was 130. He was admitted to the hospital. He had negative blood cultures. ID cleared him for intervention, and the heart team discussed the case, and the patient was considered to be a not good candidate for surgery and was advised to proceed with transcatheter valve-in-valve mitral valve replacement. So the procedure detailed, the patient was brought into the cath lab. Access was obtained in bilateral femoral veins in the left common femoral artery, and also access was obtained in the right radial artery. Because of the vegetation that was noted on the leaflet, sentinel device was placed using a Grand Slam wire. The filter was deployed in the innominate and the carotid artery. Then a temporary RV pacing wire was placed as well. And patient received full heparin anticoagulation. The transseptal puncture was performed, and then balloon septostomy was done with the 12 millimeter Mustang balloon. A wire was passed into the LV and exchanged for a safari wire. The delivery sheet and the 29 millimeter Sabian Ultra Brasilia bioprosthesis was introduced and deployed during rapid pacing. And you could see in the image that the balloon ruptured during valve deployment. Play this video one more time. So the delivery system was attempted to be pulled back. However, a portion of the balloon became stuck on the interarterial septum. Several attempts was made to free the lumen, but ultimately the delivery system catheter was cut. The outer tube was removed, and a 12 French curved catheter advanced into the interarterial septum through the 16 French groin sheath. However, the nose cone and the distal portion of the balloon became separated. The catheter tip eventually migrated into the LV, and you can see that on the TTE images. At that time, the surgeon and the structuralist decided to use the Ono retrieval system. As you could see, it's a 35 millimeter basket that it has a tearaway sheet that can allow you to introduce it into the retrieval sheet of 12 French or higher. It has no flow limiting design, and it has a 30 millimeter snare that you can use to retrieve the objects. So 26 French gourd dry seal was placed in the right femoral venous site. Then the 12 French steerable catheter was advanced into the left atrium that was used with a multi-purpose catheter, and a 30 millimeter gauze neck snare was able to snare the balloon tip into the left ventricle. The Ono catheter, however, was able to retrieve the balloon, but eventually got stuck into the valve frame. Then the steerable catheter was advanced again through the hole, and the Raptor snare was used to free the Ono from the valve frame. Then was able to collapse back down into the right atrium and down into the right iliac vein. The whole system was built, and the bear close device was deployed at that time. As you could see at the end of that image, that you could see that the balloon tip there in the Ono catheter, and that's the balloon outside the patient. The resolution of the challenge, then after that, we used the internal pacemaker of the patient and a 28 millimeter non-compliant balloon across the mitral valve to fracture the valve. The balloon was inflated, and the TT and TEE showed good expansion of the valve with no residual leak, and this is the final results. No further intervention was done after this, and the patient went to the floor. He was discharged home after 2 days, and the surface echo second day showed no valvular or perivalvular leak. So the key learning point from this procedure is procedural planning is critical for success. You have to recognize balloon detachment during delivery system retrieval, and to understand the potential role of novel retrieval system in your cath lab. Thank you so much.
Great case. I think anybody who's done mitral valve and valve would absolutely not want to see that happening when you deploy your valve. Any thought why the original balloon ruptured? Because you weren't really attempting to fracture a valve. You were just deploying your initial valve at
correct.
At whatever you thought your nominal atmosphere would be, right?
Right. I think I'm not sure why the balloon ruptured. So,
how many extra cc's do you know, by any chance? How many extra cc's you put, or?
I don't know that information, unfortunately.
Great case, Sensei, but could you tell us the ID part of the case, that he has a vegetation, and then how long you wait to sterilize the cultures and anything on the CT?
So nothing on the CT. The vegetation felt to be sterile. The patient had the infection in June of 2023, and he was admitted to the hospital in January of 2024. And he already had negative blood culture, so they felt it's sterile. We could proceed ahead with the procedure. We just wanted to make sure that he doesn't embolize from that vegetation, and the sentinel device was used for that reason.
One more question. I think at some point you said that the balloon was inside the left ventricle.
Yes.
Any thoughts about actually going with the Ourn and trying to snare it and like retrograde from the aortic valve instead of trying to interfere with a kind of underexpanded valve at that point?
I mean, that's, I think, a great idea, but I think the surgeon was keen on using the Ourn retrieval system at that time, and the team decided to use it. They actually, during the procedure, they called the guy who invented the Ourn retrieval system to guide him through how to use it.
So tell us, how did you unstuck the owner from the valve with the biotome? When the basket got stuck to the valve, you took a biotome and freed it. How did you do it?
So I didn't do it personally, but I think they used the snare to free it from the frame of the valve through the steerable catheter. They had multiple attempts to try to free it.
And what was the backup plan? Sternotomy or no?
The surgeon was in the room, so I think, yeah, sternotomy was a backup option.
Great. Thank you.
Thank you so much.
Next, we have TAVI, Basilica, and left main rescue by Dr. Ali.
I'm Dr. Asim Ali, Interventional Cardiology Fellow from National Institute of Cardiovascular Diseases, Karachi. I have nothing to disclose. I'm presenting a challenging case of 79-year-old female with hypertension. In 2012, she underwent SAVIR, but we couldn't find previous records. The only detail we could confirm was that she has an 18-millimeter surgical valve ring. Now she presented with worsening shortness of breath. Her LHC showed non-obstructive coronaries, and STS score was 5. Her echocardiogram showed normal ejection fraction. She had severe aortic regurgitation with moderate aortic stenosis. The real clinical challenge lies in her CT scan findings. Her left cusp height was more than left main height, measuring 13.7 millimeter and 6 millimeter respectively, with a VTC distance of 3.2 millimeter, indicating a very high risk of coronary occlusion. Additionally, she had highly sequestered sinuses with average diameter of 23. The heart team decided for valve-in-valve TAVR with left basilica. Her baseline T images showing degenerative valve along with severe aortic regurgitation. Now, I will quickly walk you through the steps of basilica. We begin by securing 3 access points. Then we took 6 French multipurpose guider along with snare inside and kept it floating inside the LVOT. Then by using a EBU 308 French guide catheter and a mother and child JR diagnostic catheter, we positioned the traversal system at the nadir of the aortic cusp. Moving on, the leaflet was traversed by electrified wire, followed by snare. Then we performed balloon-assisted basilica with 5-4 balloon. Following this, flying V was positioned and straddled across the leaflet scallop. And there it goes. The leaflet was lacerated by electrified wire, pulling out both systems. And on the left, red arrows pointing towards the lacerated leaflet, along with pressure flow across left main. Considering highly sequestered sinuses, we decided to put a protection wire along with guide liner and balloon inside left system before valve deployment. Then Evolut R 23 millimeter valve was positioned, aiming at a slightly deeper placement. And then it was deployed. Injection by pigtail confirmed left main patency. However, we kept the jailed wire inside left system for potential chimney stenting in case of left main occlusion. Finally, we took another jail guider and engaged the left system through the valve struts, selectively confirming left main patency. and indicating that the leaflet laceration was well enough. Here, the operators had debate whether to perform IVS to rule out any protrusion of the torn leaflet inside left system, but eventually decided to end up the procedure here based on angiographic evaluation. T images confirmed no PVL, AR, or any pericardial effusion. But unfortunately, 2 hours after shifting the patient to CCU, she had VFib, defibrillation and CPR were initiated. Suspecting left main occlusion, she was shifted back to cath lab, and upon arrival, we immediately put her on ECMO. While continuing the CPR, the left system was engaged with JL guider that showed no flow across left main. Then we took BMW wire that passed down the left system easily, followed by ballooning. Then we performed orthotopic stenting with 4018 stent. After that, flow was achieved. And following this, the stent was post-dilated. And here's the final result with well-established flow across left main, the left system. And finally, we put the patient on IBP2. Finally, T images confirmed LV contractility with no other complications. Despite all these efforts, unfortunately, patient couldn't survive after 2 days. She had worsening renal function and was on continuous renal replacement therapy and developed DIC2. So among possible causes of left main occlusion that were published in JAG by Jafar Khan, what we believe that in our case, incomplete displacement of the lacerated leaflet was the cause. Because of the highly sequestered and small sinuses, the leaflet splay was not well enough. So in this context, what we learned from our case that angiographic evaluation of coronary perfusion after valve deployment with wires across coronary ostia may be deceiving, and one must always perform IVS before completing the procedure in such high-risk anatomy to rule out any partial obstruction of the ostia. Lastly, I would like to thank my mentor, Dr. Abdul Hakim, and esteemed faculty.
Great case, and thank you for sharing it. I know a lot of people share only successes, so we all learn from like failures also. So thanks for bringing it. My first thought that actually came in mind when I saw this case is why not surgery? Like you start with a 19 millimeter surgical valve. You're gonna give a small valve, no matter if it's supraannular or not. You're definitely having patient-prosthesis mismatch. To my mind, at least, that patient is like surgery with some room with enlargement, so that would allow you in the future also to do a second case if needed, and will actually give you better hemodynamics, especially when you have like sinus sequestration. You know that fracturing will actually sequestrate things even more. That was the first thing that came into my mind. Did you guys discuss about surgery and like offer like?
Yes, patient had already history of SAVR in 2012. She was old, around 80 years, and the case was discussed in her team, and surgically she was turned down for.
And I know you were discussing IVAS even before you concluded the case. So what was the discussion? What was the thing? Just looked okay, or what was? Can you walk us through the discussion?
At that time, after completing the procedure, so the discussion was same that the patient had highly sequestered sinuses. So the operator actually, one of the operator wanted to do IVAS, but the other decided that angiographic evaluation is enough, and we could actually engage the left system selectively. And in that time, in between, almost 30 minutes to 45 minutes has passed. So that was the discussion.
And can you walk us through using sapien versus core valve in this case?
We only have evolutar core valve.
Any questions from the audience?
Thank you.
Alrighty, next we have Dr. Shani for percutaneous retrieval and replacement of dislodged left atrial appendage occluder.
All right, hi, I'm Rahul Sani. Thank you for having me here today. I have no disclosures. So our patient is an 86-year-old man with a history of longstanding persistent AFib, status post to prior ablation, and frequent falls while on anticoagulation. So he was referred for left atrial appendage occlusion. So he underwent this with a 27 millimeter Watchman Flex device. And during the initial deployment, there was a partial shoulder on the mitral side. Multiple repositioning attempts were performed. However, ultimately, this was the best result possible. So there was a discussion whether to remove the device and abort completely, but the operator felt that they could go ahead and deploy this, so they went ahead and deployed this device. There was a small peri-device leak, which they thought that would probably heal. So this is taken from the original operator's report. All the criteria were met, the device was deployed, the patient was discharged on aspirin and apixaban. The 45-day TEE looked like this. So it looks like there's a jellyfish that's floating in the left atrium, and it is partially attached to the left atrial appendage. You can see again here, it's really only attached under the Coumadin ridge. So good news is that it hasn't flown away, but the bad news is that it's just sitting here flapping in the wind. And just another 3D here. So heart team discussion, this patient was admitted after the TEE and started on a heparin drip. And ultimately we just considered whether to take this patient to surgery, but decided that we could attempt this percutaneously with a surgeon on standby and a circuit on standby. So the plan was to grasp the device and with one quick movement, try to pull it out basically, and hopefully dislodge it and not lacerate the left atrial appendage. But just in case, that's why all this was on standby. And of course, this was a different operator than the original implanter. So we're able to go transeptal and use rescue forceps to grasp the device and get a nice hold of it. And oops, able to detach it here, and there we go. We're able to pull it into the dry seal sheath. So got in the sheath, so everyone's excited. And really quickly, it's like, okay, effusion, 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 and there's no effusion, and there's the trophy that we were able to successfully remove. We quickly shot a left atrial appendage gram as well to make sure that it was intact, and indeed it was. And so subsequently, we put in a 22 millimeter amulet device, which fit nicely, did not have the same issues as the initial Watchman device, and also no pericardial effusion on this one. So this was just funny to me. For some reason, the device was sent to pathology, and so the path report was, in case there's any ambiguity, it was a Watchman. So our take-home messages from this are to ensure proper left atrial appendage occluder device position, minimize protrusion prior to deployment. When the team says, hey, there's a shoulder, what do you think of that? Maybe don't leave that device behind. Percutaneous recapture is possible, and including with manual extraction. You want to have a heart team discussion before doing this, and we want to review these cases carefully, especially with more devices on the market now, to make sure you choose the right device for the right patient. Thank you.
That's a great save. You didn't call your friend with the Uno basket? So can you comment on the anatomy of the appendage for everybody? What do you guys thought it was?
Yeah, it looked like, I don't know if I'm able to go back into the slides, but it looked like it was kind of a more cauliflower-shaped appendage, and that's why there was multiple lobes and why the device had a significant shoulder on one end.
And how big was your dry seal that you pull it through?
This was a 16 French, I believe.
It looked like a long sheath. Is it 100 centimeter or
Yes.
80 centimeter?
Yeah, we wanted to get it up and actually bring it right, go transeptal with the dry seal itself.
Okay. Is anybody else has experience with fetching these?
thankfully, our sheath was able to be coaxial with the device itself, so we're able to just pull it straight in. The next time we'll try the Ono.
I have no financial.
If you go back to how you snared it, I think it's there are two ways to do it. I think once you engage the bar joint, I think this was a pull. It's more probably advisable to engage with the bar tooth and then advance the sheath to swallow it rather than pull, because if you're pulling, you're putting a tab in the heart.
Sure.
These are great points, and yes, it's like more like a push and pull strategy.
Yeah,
like
to resheath the device.
because you're not like dragging things
Right.
like so thin, like you're guided. Like your sheath is actually coming over the device. And,
Right.
What do you think happened? I guess that's my question, because I'm like, if you think that you have adequate compression, I think in the images you have more than one shoulder out. I think like a good portion of your device is out, but. Did you guys do like the tag and pull test, like make sure that nothing is moving? And most importantly, do you guys feel it's a depth issue? Why was not like the Watchman device sitting deep enough for you?
Yeah, so we weren't the original implanters of that device. This patient ended up, happened to come into our institution for the TE, and then we kind of took this one over. But just from what I could gather from the deployment images and talking to the people involved was that the device, it just really wasn't seating very nicely. At the time, Amulet wasn't available, and so the operator was really just trying to make do with this device. And even with the shoulders and stuff, they did do a tug test and everything, and so it seemed to be okay, but there was a lot of kind of feeling from the staff involved of, we don't know if we should have really left that one behind.
And another quick question is, was the MR looking worse in your TE? Because there seems to be some extent of MR right now. I don't know if in the initial imaging, did you have like same amount of MR, or do you think there's like injury to the mitral valve as well? And
We didn't pay that close of attention to it, but clinically speaking, the patient didn't have significant MR on follow-up after this.
Great game.
Thank you.
All right. I think that's our last one. Dr. Omar will be presenting a TAV in SAV, and how many bioprosthetic valves will we fit? I'm really excited to see how many.
There's going to be a lot. All right, thank you everybody for sticking with us for the last session on Friday. So this is a 43-year-old man coming to the hospital with acute bioprosthetic AI of a previously placed transcatheter aortic valve. So I'll talk you through his history. He's 43 once again. So 15 years ago, he had a Bentall and bioaortic valve replacement for an acute aortic dissection and aortic insufficiency. 10 years after that, he presented with acute bioprosthetic AI. He refused reoperation at that time. The surgeons tried to convince him to put a mechanical valve in, and he was a competitive snowboarder and surfer, and said that that was not in line with his lifestyle at all. And was kind of shopping around, going to different places to see who would put a TAVR valve in, and this is around 2014. So it was my center before I was there, and they put a valve in. So he underwent a TAV and SAV 34 millimeter core valve at that time, and then they post-dilated it because of some infolding that had occurred during the case. So 1 month later, interestingly, he had acute central AI of that TAVR valve. It was delayed, assuming possibly due to the post-dilation, but there was no AI on the TTE at discharge. So that required placement of a second valve, another 34 core valve inside of it. So this time he presents, he has a dilated LV, his EF is mildly depressed here, and he has severe AI, and you can see that pressure halftime here. This is what the valve looks like with the shadowing on TEE, but you can appreciate that there is severe AI with holodiastolic reversal. So he also had a draining wound and granulation over his prior sternotomy scar. Once again, this is a guy who surfs all the time and is always in the water. So there was concern here. He did have some leukocytosis. The wound was cultured and he was started on antibiotics, but plastic surgery was consulted and they were concerned for infection and wanted to wash that out and possibly do a flap and repair. So many things going on at this point, right? So this patient understands that he's 43. The overall consensus is that he should get all of this taken out and have a mechanical valve placed, or at least a surgical bioprosthetic. Vehemently opposed, said he'd rather not live if he can't get this done. So at that point, a lot of things to discuss here. Surgical explant and valve versus a third TAV and SAV. His age obviously goes for surgical explant. It's much more durable here. And then he would likely not need future procedures versus, anticoagulation is something that is against his lifestyle. So that goes for third TAV and SAV there. It's his preference as well. And then this question of a sternal wound infection was really complicating things, and our CT surgery colleagues were pretty concerned about that as well. And then he's in acute cardiogenic shock, so that obviously increases his surgical risk. So here is his planning CT. You can actually see that the two TAVR, the two core valves are overlaid quite nicely. And this is prior to the days of cusp overlap technique and obviously prior to the days of FX. So I was actually pretty impressed with that. That being said, he actually has very, very nice dimensions here, huge sinuses. You can see the VTCs are quite massive, so there wasn't really concern for coronary obstruction if he were to undergo a TAV and SAV, or TAV and TAV again. And so given the fact that he wouldn't require any leaflet modification and all that we discussed before, we went ahead and did the TAV and TAV here. This is our access. He did have a hemiarch repair, which we were concerned about, but actually that was traversed pretty easily. And then we deployed the 23 balloon expandable valve at node 5. And obviously there's always a concern about preventing coronary obstruction and versus leaflet overhang. I think we could have gone a little bit higher, but as many of you know, once you get caught, it's hard to really move your tab. So we wanted to go a little bit higher than we did, but I think it was an adequate spot that we ended up in. So this is our angiogram. He had preserved coronary flow. He had no dissection. And then his mean gradient was 10, so fairly acceptable. It's a small valve, right? He's 43 and very, very active, so it's likely that this is not something that's going to be very durable. But takeaways here is TAV and TAV and TAV in SAV can be performed safely in patients without other surgical options. Obviously, a patient-centered approach must be used. And in this case, the fact that he had large sinuses and high coronary implantation from his prior Bentall really assisted in preventing a tube graft phenomenon here. So really underscores the importance of getting your first valve right, and obviously we're all still learning what that means, but 10 years ago that was definitely not a concern. These are my co-operators, so I wanted to thank them.
Wow, that's a lot of valves.
A lot of valves.
So tell us, obviously you had a discussion with the patient. He absolutely said no, so your hand was forced. All of us would prefer a mechanical valve. But the first evolute failed in 1 month.
Yeah.
So tell us about that. And the second question is, was the SAVR, what kind of SAVR he had? And was it fracturable? Was it modified? Or what was done for index procedure?
Yeah, so the index procedure, it was not modified and not fractured. And like I said, this was back in 2014, so before a lot of literature on fracturing was available, that they did the TAV and SAV. But like you said, the index valve, the index TAV actually was ballooned. It was post-dilated, and it's possible that that ballooning was a little too aggressive. I didn't actually have the size of the balloon that was used. Looked at the echo from the discharge, and there was some mild central AI that they ended up not calling on that echocardiogram, but obviously that got a lot worse as time went on. So I think there was some damage done to the leaflets of the TAV that just got worse over time.
Nice case. A few thoughts. First, I know we all have picked up a mechanical, but at the same time, just because you're not getting a mechanical doesn't mean that you can't get a bioprosthetic with surgery and remove a lot of the valves that are already there.
Yeah.
So it kind of and I think in the conversation, it kind of pushes the can down the road.
Yeah.
Because those valves are not going to last him 20 years by no means. Second question is, looking at the valve placement at least, I know you guys were trying to go for node 5. At least on the quick picture that I saw, you're kind of looking like annular to the first valve. So the first surgical valve. So it looks like your sapien is actually positioned a few millimeters below your first surgical valve. So kind of whatever your annular was at that point from your surgical valve actually defines how big your new S3 is going to be, so regardless of the evolutes that are there or not. So did you think about like positioning supraannular to the initial valve? So that way you can actually take away that that stricture component that comes from the surgical valve, especially if you're not sure if it was fractured or not.
Yeah.
And the third question is, what are you guys thinking about anticoagulation in this one? Because 4 valves in there, I think the third one degenerated in 5 years. So, like, what are you thinking about keeping it like
Right, yeah,
longer?
so that is a concern because he degenerates valves very, very quickly. So to the first point about a bioprosthetic surgical valve, agreed, we brought that up to him, and the obvious choice would have been to remove everything and put a larger bioprosthetic if possible, which he did not agree to. He had a competition literally in a month. That was the biggest thing that he had to do, so he had to get there. And he was going to make sure that he got there. So that was number one, agreed. We discussed that. Number two, yes, I think that had we put it, the concern was that if we went too supraannular compared to the original salve, were we going to be able to land in a place where we wouldn't disrupt the coronaries? And our measurements didn't get us to a place that we could do that. So we ultimately decided to go with the small valve because that is where our coronary risk plane was actually the safest. But agreed, we did try and measure it out to get to a point where we could do that. And then third, he is on a DOAC. He's on a DOAC plus Plavix, and we kept him on that for 3 months. Now that's something he's going to stop as he needs, but it was better than warfarin for him. Yeah, thank you.
Thank you very much, guys. That's all the presenters, and I think we're done with this session.